The agenda for today is I'll give you a little introduction on the patents and how the pharmaceutical companies get those, which leads to generic medicines, and also I'll speak the difference between generic and biosimilar drugs, and then I will go more into detail of generic Imatinib, which I think is why we are all here. And as I said, Dr. Bulusu will speak about the efficacy and safety data that we have to support the use of generic Imatinib, and a study that he has done within his trust. And then what we can do is also to make a little bit more interactive the session, because I could talk for ages and you all get bored. After lunch, that can be quite difficult and fall asleep. We don't want that. So we'll have some switching questions and Q&A session, so you can ask whatever is burning. So just as I said, a little introduction within the subject. I just wanted to give you a little bit of background within the patent and how they work. So normally when pharmaceutical companies manufacture a drug, they first of all have to get an approved by the regulatory body. In the US is the FDA, here is MHRA, and they apply for it and they obtain a patent. This patent will assign them an exclusive legal right. That means that no other company can create or sell that drug for as long as the patent is in effect. This usually is between 20 years, but it depends on many factors how many years actually the patent is in effect. The drug patent is an exclusive legal right that they have, not only the brand name, but they also is the trademark, the product dosage, the ingredient formulation, and all the manufacturing process. And this is what it leads to allow them to have that monopoly for certain drugs. And obviously, when there is no competence, price always goes up. Again, without boring you too much and going too much into the detail, normally a drug gets discovered, and when they do that, they register a patent, and that is when the clock starts ticking, because they have normally 20 years then. And those in those times, they have all the clinical trials with different phases, first in animals, then in humans. And then once all of this is satisfactory, which it is quite difficult to get a drug farther down the line, then they have what we call the patent in effect. So all the years that are remaining is what they have as protected time to commercialize that drug or market that drug without having any other pharmaceutical companies as competence. And as you can see, it's a little bit little, but there is actually quite a lot of years between a drug gets discovered and they actually marketize the drug. After that, then other companies can start making generics. And this is what we are going to talk about this afternoon. So a generic medicine is something that is created, is a drug that is created when the patent for a drug runs out. So other pharmaceutical companies can make their own copy of that named drug, and that is what we call generics. They are identical as the brand name drug in dosage form, in effectiveness, in safety, in strength, and the route of administration, and also quality. Although these generic drugs are chemically identical to these branded name drugs, they are normally cheaper, and I'll come to this and the reasons behind that in a minute. And the reason why the NHS always strives to use these generics is because and it happens not only within cancer drugs, it happens in antibiotics, in heart medicines, in painkillers, any sort of drugs that you can imagine. If there is a generic in the market, we'll push to try to use it within the NHS. And the reason is we have quite a tight budget, and we have to use it wisely. So this use of generics allow us to make considerable savings in treatments, which makes us improve the healthcare for all of us. The generic medicines facts that I want to make clear this afternoon, and if there is something that you need to take home from what I'm saying today, is these three things. Generic medicines are the same high quality as their branded name ones. And this is because they have gone through a rigorous review for the regulatory bodies like MHRA in this country, and the same process of approval that other drugs. And therefore, they have the same safe, effective, and high-quality characteristics that the brand name. The generic medicines can look a little bit different, and I think that's why sometimes it's a little bit confusing. And we can see difference in sizes, sometimes in colors, but this doesn't impact in how the medicines work. And most importantly, generic medicines cost less money. And I'm sorry to keep banging on that, but economy for the NHS is quite important. The generic brands are considerably more cheaper than the brand names. And the reason behind it is because these other pharmaceutical companies that didn't make the discovery of this new drug in the first place, they don't have to put all that money and invest in research to launch the drug. They just need to make a copy of it. And the copy is considerably cheaper because you don't need to pay all that research. So that's why they are cheaper, but quality and safe and effectiveness is exactly the same as the brand name. I also wanted to talk about generic and biosimilars. I think, I don't know if this is the case here, but in some patient groups, I think there's a little bit of confusion, and I think I understand the reasons why, because there is certain things that are similar. So generics and biosimilars, they both are available or come out to the market when a patent expires, and they are both cheaper than their brand name drugs, and they also, both of them, have the same clinical effect. However, there is substantial difference that I wanted to make clear today in case someone was wondering within our audience. So the traditional generics, or what we call generic drugs, are very small and mainly simple molecules, when biosimilars are larger and more complex molecules. And I tried to put that picture over there. I don't know if it's that visual, but they are actually very big molecules. That the generic ones, they essentially are chemically produced in a standard manufacturing process, and that's what we call synthetics. Is to make it a very simple example, is kind of like cooking. You mix a few ingredients and you get your drug. With biosimilars, it's not as simple as that. You actually need to produce living cells that requires a very specialist manufacturing process. And then more importantly, generics are identically structured as the brand name drugs, when biosimilar are highly similar, but we can't claim that they are identical. And then generic medicines are usually oral medicines, when biosimilars are normally intravenous medication, sometimes subcutaneous as well. And what you can see on that table is actually the development time is considerable larger within biosimilars. For generics, normally when the patent runs out, in 2-3 years, we got the generics in the market, and the development costs are actually not that much when we compare them to biosimilars. So biosimilars are cheaper drugs than their brand name drugs, but they're still fairly expensive drugs because of the complexity behind them. And now talking about Imatinib, which I think is what we are all interested on this evening. So generic Imatinib came when the patent expired, and this happened in early 2015. The protection around Gleevec came to an end, and this is when other companies start to marketizing generic Imatinib. There are currently several versions of the generic Imatinib available in the UK, and they are all licensed for GIST. And the NHS, as I mentioned earlier, must use its resources efficiently. So patients that were taking Gleevec, we are now switching to generic versions of the Imatinib. Now this happens at different timelines depending on like the area we live, because NHS has this kind of like different way of approaching certain changes for improvement, but sooner or later the switch will happen. And what I wanted to make clear is that the generic Imatinib has the same composition, the same quality, the same effectiveness and safety as Gleevec that some patients have been taking for years. So just as a little reminder that, as I said, the patent of Gleevec, which comes in that image over there, came to an end, and then it takes a little while between the US and UK difference, but essentially in February 2016, a generic version of Gleevec came to Europe, and then we have an awful lot of pharmaceutical companies start to try to make money of this copy of the Gleevec, and this is just like some of the ones that have marketized this generic Imatinib within the UK. In terms of efficacy and safety data, the generic Imatinib have been used in the UK over 4 years without problems for hematological cancer. I'm not quite sure what was the reason behind it, but they switched to generic Imatinib, I guess because of the pressure in terms of like the volume of patients that we have within the NHS in hematological cancers is higher, and the switch to generic Imatinib was done earlier in then. And the evidence from this first switch indicates that generic Imatinib is as effective, and the profile of side effects, as you can see a little bit in this graph, although it's a bit small, is very similar. We have the generic Imatinib on blue. Light blue means grade 1, which is the least severe side effects, which is quite reassuring to see that Imatinib is quite well tolerated, because most of the side effects are not so severe. And as you can see, the comparable between the blue and the yellow lines, which yellow being our Gleevec brand, are fairly similar. And now I'll pass you on to Ramesh, who is going to talk about the study.
Thank you. Right. Okay. So thanks, Laura. So we got to know about generic Imatinib late end of 2020, early part of 2021, when we got just an email from the pharmacy, oncology pharmacy. Oh, by the way, we are switching, and we're all are very nervous about switch. We want things to be the same, and we don't want things to change. Same thing with me, same shirt, same trousers, same shoes and same socks, for the last 20 years, and my wife is fed up. But that's where we are, we are human beings, so we're always very nervous about change. So what we have done in Cambridge is we have a cohort of GIST patients who are on various kinase inhibitors, the tablets. So we started collecting data. I think the most important thing for us is it applies to every single cancer. Data is very important. You have to collect data. Otherwise, you wouldn't know what you're doing in 3 years, 5 years down the line. It doesn't have to be research. It's just a purely simple clinical data. So what we have done is, so this was the Imatinib Gleevec we were been using for about 15, 16 years, 17 years now. And temporarily, we were using this particular generic Imatinib, and then this came along, and currently we're using this one, which is a very tiny tablet compared to your Gleevec. And there are people in this audience who will vouch for saying this tastes terrible. But there's a secret how to take it, because one of my patients demonstrated how to actually get rid of the terrible bitter taste in the mouth. So basically what we have is NHS England use this one first, the Tiva one, And for some reason, Teva apparently has bumped up the price. So now we're using this one in this corner here, the Amarox one, which is much more cost effective compared to the Teva one. So this may change again in the future if Amarox bumps up the price, we go to somebody else. As Laura was pointing it out, the quality assurance for this generic imatinib is at a level where we expect it to be. We're not buying somebody from our back garden who's making it, just because they know how to make it. So the quality assurance is as high as your branded imatinib. This is for all generic drugs. So this is a population study in patients who have been on either Gleevec imatinib, branded imatinib, who've been switched to generic, or patients have started generic imatinib de novo, meaning they just started on generic imatinib because they've been diagnosed in 2020, 2021. So we recorded the side effects prospectively, asking a simple questionnaire for the patients, and also looking at their response on CT scans, because one of the anxieties is it being absorbed? Is it actually doing its job it's supposed to do? And in selected patients where we had some anxieties, we also started checking our plasma imatinib levels, the trough levels. This is not a standard routine practice in the NHS. We don't do that routinely, checking the plasma levels of the drugs. But in this case, we thought it's a reassurance for us as specialists treating the patients, also reassurance for the patients and the families that the drug is getting in, or if they're getting side effects or they're getting too much of the drug. So 48 patients, duration of the generic imatinib, we started around April, so around 10 months now. Previously, who've been on Gleevec switched to generic is about 39 patients. 9 patients actually started de novo generic imatinib as their only drug. What we have learned in the last 10 months is that majority of the patients, the side effects when they switched were temporary and transient, and they got better. And the patients who have had generic imatinib from day one, they had a similar kind of side effects what we saw back in 10, 15, 20 years ago with the imatinib, bit of nausea, bit of puffiness of the face, bit of ankle edema, fatigue, diarrhea, muscle cramps. So they're very, very similar. A couple of patients a bit different. This one patient struck with me. This is this patient here. He started imatinib, and within a couple of months, he had neurocognitive problems. He couldn't remember things. This is something we have never seen before with imatinib. We stopped the imatinib for a couple of weeks and restarted at a very low dose, and then slowly built up the dose, and he's been fine. So there's something peculiar about that particular patient where we had an unusual side effect. So out of the 48 patients we have seen, 10 patients had side effects which we felt were linked to the imatinib, generic imatinib: fluid retention, joint pains, diarrhea, memory problem. One patient dissolves in the mouth. This is 4 out of the 10 patients. When you put the tablet in, the film coating is not strong enough for it to stay there. It dissolves and tastes a horrible taste in the mouth. And one patient, he showed me how he took it. In between the teeth, take it there, and then big glass of water, it goes down. So that means it doesn't stay in the tongue for too long. But that's his technique. You can master it, just between the teeth there like that, and then swallow it. And it goes straight down, apparently. A couple of patients who had nausea, dizziness, abdominal pains, and also bloating, cramps, they were very worried that their gist is coming back. They were convinced that this is actually just tumors because they had peritoneal disease, and these were the symptoms they had. They've been on imatinib for a long time. So what we have done in these patients is started checking their plasma levels. We gave a choice to the patients. Do you want to stay on imatinib, generic imatinib? You're doing fine. CT scan looks good. Do you want your levels checked? And most of the patients said, I don't really bother about it because I'm fine. Side effects are not different to what I had before. So in those patients, we didn't routinely check the plasma imatinib levels. In patients who were concerned or were anxious, we said, okay, let's do it. So this data goes back 15, 20 years ago when we knew from the CML data and also possibly from the GIST data as well, that the plasma trough level, meaning that you need to be on a steady state of imatinib before you check the trough levels, meaning that you can't do it. For example, you take a tablet today, for the first time, you can't check the levels tomorrow. They need to be a steady state, absorb it very well. And you take the plasma sample, a blood sample, before your next dose. Say, for example, you take the tablet, say, 6 p.m. last night, and you do the test today, that is a tough level. But if you take the tablet, say, this morning at, say, 12 o'clock, 11 o'clock, and do the plasma levels now, that's not a tough level. So you need to be before your next dose tablets. And we have two things we test. One is the Imatinib levels, and also norimatinib, which is one of the active compounds, daughter compounds of the Imatinib. We check those two. And the levels where we find there is satisfactory response, correlating with response, is about 1 milligram. So if you have 1 milligram of Imatinib per liter, or a quarter of that would be norimatinib, then we feel that that's adequate or satisfactory level based on the data from going back a number of years ago. So if you look at the 1, 2, 3, 4, 5, 6 patients, this patient, the first one, had the disease actually progressed within 6 months after switching to generic Imatinib. So the anxiety we had was, is it because of the switch? Looking at the plasma levels, they were pretty good, both the Imatinib levels and so the suspicion there was that there's a clonal resistance which has developed over that period, not necessarily due to switch from Gleevec to generic Imatinib. Then if you look at patient number 4, side effects on generic Imatinib, bloating, abdominal softness, feeling, diarrhea. Again, levels are not too high. We were expecting them to be something like 5 or 6 kind of thing, but they were where we expect them to be. So again, we didn't feel that the generic Imatinib was contributing to symptoms, and we managed the patient with some Buscopan and some anti-diarrhea medication. Seems to have settled down. This is a worrying patient, rapid progression, very rapidly progressed on switching from Imatinib, Gleevec to generic Imatinib. But if you look at the plasma levels, they're actually quite high, the highest in that cohort. So again, we didn't feel that it was the switch which contributed. Perhaps it was the clonal resistance. This patient had a new liver lesion which was developing while on adjuvant Imatinib. Again, the concern was the Imatinib being absorbed. Again, levels are close to 1. But what we do know that with time, the plasma levels do come down a bit, because there's what we call a self-induction of the Imatinib metabolism inside the body. So if you start on day 1 and 3 years, 4 years down the line, you're probably getting a bit less Imatinib than you were getting right at the beginning. So perhaps sometimes the trough levels do go down. Other thing you need to be careful is, what we are measuring is the levels in the blood. We're not leveling the plasma, the tumor levels in the tumor. So the presumption is the plasma levels of the drug, whatever the drug is, reflect what happens inside the tumor. Peter Hohenberger did some work on this a number of years ago. He's from Germany. But the presumption is that if you got adequate plasma levels, you're likely to have adequate intratumoral levels. It may not be true, but that's the kind of a presumption. So what we felt was that in the last 10 months, what we have seen is that, yes, some patients have progressed while on Imatinib. It would have happened anyway. It's unlikely to be linked to the switch from Gleevec to generic Imatinib. Then I wanted to just give you some idea about what actually happens. There's some rare side effects which we have seen both with Gleevec and also with generic Imatinib. This is a patient who had a high-risk gastric cyst resected and has been on adjuvant Imatinib, Gleevec. And you can see her phosphate levels in the blood went down very low. Normally, phosphate levels are about, you can see it very well, just about 0.9 and above. So that one, she started Imatinib around here. That's Gleevec. And within a few months, her phosphate levels went down. She became unwell. And we temporarily stopped the Gleevec and supplemented the phosphate. and then recommence when the phosphate levels come back. And then you can see that the drop again is there, but not as low as it was. So this is a very uncommon side effect. Sometimes maybe underestimated side effects because we don't check the phosphate levels that routinely. This could be potentially life-threatening sometimes if your phosphate levels go down very low. That can cause problems with the heart. Very rare side effect, but this happened with Gleevec, not with generic Imatinib. Okay, so this is again what we call as a class effect, meaning that most of the drugs ending with nib, Imatinib, Sunitinib, Regorafenib, all the nibs, they tend to have this kind of a class effect where the phosphate levels tend to go down a bit. This is another side effect of all the nibs. Transaminitis, meaning inflammation of the liver. Transaminases are liver enzymes, so it's a liver dysfunction or liver inflammation or hepatitis. We don't use the word hepatitis because that has a different connotations. So this patient, if you look at the enzyme levels, normally they should be around here and below. And what you can see is that baseline before Imatinib, and then on a half dose of Imatinib, this is back in 2021, and went up and came off Imatinib, and then gave some steroids, and then reintroduced Imatinib, same dose, went up, came down, went up, came down. So this patient is very, very sensitive to Imatinib, and we could not get the dose right, scheduled right, and we actually come off the Imatinib completely now, and he's in remission. He had metastatic disease which is completely resected. He's in remission, but I need to find out how to put him back on Imatinib. We've been discussing with our colleagues at the Marsden and also in Dana-Farber and MD Anderson, see whether we can use low-dose steroids, a tablet called prednisolone, to dampen the liver inflammation and gently reintroduce Imatinib. But he's been off Imatinib for 3 months now, and scan looks fine. But I'm worried because he's got metastatic disease at presentation. Want him to be on drug. And the mutation is very sensitive to Imatinib. So we want him to be on some dose of Imatinib if we can, because this is potentially life-threatening side effect. It can cause liver problems, liver dysfunction, so we don't want to risk that. But at the same time, we need to get the balance right about keeping his disease under control or stopping it from coming back, and also not doing too much harm to him by causing liver problems. So this actually was related to Gleevec, not generic Imatinib. So you need to be very careful before you blame the drugs. Other thing is we look at the concomitant medications, meaning other medications patients have been on. Recently patients have been on statins, and they had one of the enzymes called creatine kinase went up, and they thought it could be Imatinib, but in fact we stopped statins and the creatine kinase levels came down. So you just need to be careful about what you want to link the side effects to. So in our experience in Cambridge, we have not seen any significant differences between Gleevec, the branded Imatinib, and the generic Imatinib since April 2021, roughly about 10 months. Transient side effects may be due to different formulations. The plasma levels were within the expected range. We have not had any concerns, because one of the major concerns is, am I getting enough drug? Second major concern is, I'm getting terrible side effects. Am I getting too much drug? So we have not seen that. The long-term data is mostly from the chronic myeloid leukemia cohorts, because they were there first. And also it's much more easier to monitor the CML. It takes a simple blood test. You don't need to have CT scans. And the data is very clear that actually there's no difference between the generic Imatinib and the Gleevec branded Imatinib. Can you get Gleevec if you have concerns, not because of anxiety, but if you have proved that your disease has progressed, and or if you got horrible side effects from the generic Imatinib? There's a process. It's a bit convoluted, complex process, but it's through called individual funding request. A couple of consultants have accessed that, and they went back onto the Gleevec, and again they had the same side effects, so they're back on generic Imatinib. So it is possible that you can actually have switch from generic to back to Gleevec. We have not done it. We have managed the side effects as we would have done 15 years ago when the Gleevec was introduced. So we have not done the switch. And also, if the patient has progressed on generic imatinib and plasma levels are satisfactory in the range we expect them to be, the presumption is possibly clonal resistance rather than actually due to change from or switch from Gleevec to generic imatinib. So that's been our philosophy in Cambridge. I'm going to hand over to Laura again because she's going to talk about the kind of questions we anticipate and also we encounter when we're switching from drug A to drug B. So, Laura. Thank you.
Thank you. I'm back. So just to finish the session, I'm going to talk about the switching common questions that we get within clinic. I think the main one is that it looks different or tastes horrible. And the reason being is because although they are identical drugs, and by saying identical we mean the active ingredient, there is also within the tablets certain ingredients that don't have a property, but we add them to make it taste better, make it look prettier, so you can differentiate from another tablet. So yeah, fancy stuff like that, colorings and coatings, anything that you can imagine. They don't have a proper activity within the clinical setting, and this is why the tablets look different and taste horrible, but I'm sure some will be trying the trick that Dr. Bulusu mentioned about the taste to help the swallowing of these tablets. These is some questions that I have borrowed from a generic Imatinib leaflet from the Medicines Information Department in Royal Berkshire. And one of the questions that I also been asked is like, if I'm already on Gleevec, will I be switched to generic Imatinib? And again, as I mentioned earlier, yes, the answer to that question will be yes. I cannot tell you when, but it will happen eventually because within the NHS, we always strive to get the most cost-effective treatments. It will depend on your local hospital or the specialized center that your care is under, and how they are getting on with this transition. But it will eventually happen. And tablets, like for example the Tiva ones, are quite similar to how Gleevec was, but then as Dr. Bulusu mentioned, they pumped the price up, so we have to switch to another one. And this is the day-to-day within the NHS, trying to keep up with these pharmaceutical companies. Other question is like, how can I be assured that the quality of this generic Imatinib is the same? Again, I hope it's something that stuck with you when I did the presentation earlier. The generic Imatinib and any generic medicines, they go through the same quality assurance that any brand name drugs. They have to be approved by the MHRA before they go into the market, and they have a very rigorous review before they have their approval. They have to demonstrate that they contain the same active ingredient as the original drug. They have to be identical in strength, in dose, and route of administration. They have to be bioequivalent, and they have to meet all the criteria for batch requirements, identity, strength, and purity of the drug. And they are manufactured in the same way as the brand name drug is like Dr. Bulusu said, is not someone just making it in a garage and selling it to us. What happens if I experience problems after switching to generic Imatinib? So because they are identical drugs, we do not expect any patients to experience any major problems when they are switched. We do like to monitor patients and check with them after the switch, and if there is any concerns like things that are little, but we call them little because they don't cause too much worries, but obviously we are not the ones that take the tablet every single day. So by all means, if the tablet is tasting horrible, I will encourage you to contact your point of contact in your specialist centers or your hospitals to try to find a solution to that, because the tablet that is not taken is not good, regardless whether if I tell you it's identical. If it's making you nauseous on the taste is just too dreadful, we need to find a solution for that, and maybe that solution is switching to another generic, but like we need to have that open discussion. We don't want you to feel that we're just leaving you in the lurch, like, look, this is cheaper, this is why you're gonna get this from now on. So please feel free to contact them, and we are here to help to find that solution. And then the other questions that I came across within the forums of the community was like, how many generic Imatinib are there? That I could count within the UK, there's at least 9 pharmaceutical companies that sell generic Imatinib. So that means there is choices. Having said that, I do believe that within the NHS we work with contracts, so sometimes can be quite difficult to get different generic versions of Imatinib if they are not under contract, depending again in your local area or what your hospital practice is. Is there a price difference, and do some oncologists use one rather than others? So yes, there is a massive price difference, and that's basically the core reason to switch to generic Imatinib. Gleevec is the most expensive, and again, NHS hospitals will procure the cheapest one, and that's why, for example, we switch now from Teva generic Imatinib to Amarox in some hospitals. Other question was, has any oncologist found any difference between the different generic and the Gleevec as far as efficacy goes? And again, because they are identical active ingredients, there is no difference as far as we know, and no difference within efficacy, but neither safety that we expect. And when switching, is it possible to distinguish between any side effects caused by anxiety and those actually caused by the new drug formulation? So unfortunately, there is no way to distinguish between what can be caused by an anxiety or like symptoms from like the switch. What I will say, I want to think that having again open discussions about this can help you to get reassurance from like healthcare professionals, which can provide you as much information as you need, and in like further detail that we have this afternoon, and hopefully that can help to find some reassurance and calm down the anxiety that can be caused by this switch. And I think this is the presentation for today. I hope you find it hopeful and like useful. And thank you so much for listening. I'll pass you to Nick. I don't know if you have any questions.